try to use an easy way to explain our physiology of the cardiovascular system. So don't stress, just follow these slides. Okay, everybody ready? Let's start. So the first part of my lecture is the normal circulation system. In the first session, I will show you the structure of our circulation system. And the learning point include the structural difference between the human heart and other vertebrates, and why do we human need 2 atriums and 2 ventricles. So I think everybody have a cell phone with you. Please grab your cell phone and scan this QR code. When you scan this QR code, you will find a website that you can vote. And please, which one of the following picture is our human circulation system? Please vote. Let me see your response, please. Okay, I will give you 30 seconds to vote. I think everybody is here. Just let me know you are here. Okay, since we don't have too much time to wait, so let me show you the result here. I think most people choose answer C, and C is the correct answer. Okay. Here are several differences between the vertebral heart. The first one, figure A, is the fish heart. You can see that there's only 1 atrium and 1 ventricle, and it's on the venous side. So please think about it. What is the problem of a fish's heart? The problem is the pump, is the engine is at the venous side. So at the arterial side, there's no engine. So the blood pressure is low at arterial side. So the fish need to swim, need to use their muscle to squeeze the vessel to move, make the blood move forward. And for figure B, it's the heart for amphibians and most reptiles, such as lizard and frogs. So what's the problem of a frog's heart at this picture? You can see that because the ventricle is not separated, so the desaturated blood will mix with the saturated blood, and the oxygenation is not perfect. So for human heart and for other birds, we have a circulation system like figure C. The human circulation system includes 2 separated circulation, include a pulmonary circulate, it's for the oxygen and the carbon dioxide exchange, and there's another systemic circulation to perfuse our vital organs. Since we have 2 atriums and 2 ventricles, we can totally separate the desaturation blood and the saturated blood. And this picture is the blood pressure in our circulation system. The arterial side, the blood pressure is around 100, and to capillaries, the blood pressure dropped to 35, and then dropped to 15 mmHg at venous side. Okay, and this is the picture show the blood pressure at different part of vessels and also the total area of our blood vessels. So you can see the total area is biggest at capillaries and small veins. Okay, I have a question too. What is the percentage of blood volume in our venous system? There are only 30% of blood in our venous system, or there are 90% of blood is in our venous system. Please show me your response. Just guess, it's okay. It's not a test. Let me know you are here. Okay, you can see that the total area is biggest at the venous side, right? Here's everybody's response. Okay, good. The correct answer is 17%. Let me show you. So this is the distribution of the blood in our circulation system. You can see that the blue part, approximately 70% of total blood is in the venous system. And here is the percentage of blood that each organ takes from the left heart. You can see our heart, our coronary arteries only takes 3% of the blood from the left ventricle, and our brain takes about 14% of blood. Okay, that is part one. And then part two, I will try to explain the contraction, the mechanism of contraction of our heart. The learning point here include the ion channels and the action potential of myocyte, and how does the cardiomyocyte contract, and what is the energy source of our heart. This is the action potential of cardiac myocyte and also the most of the skeletal muscle, include phase 0, phase 1, phase 2, and phase 3, and phase 4. Okay, which of the following ion is not involved in this action potential of cardiac myocyte? Everybody, if you are here, you have a cell phone, please vote and let me know you are following our class. So don't be shy. Okay. Here is your response. I think everybody already know the action potential of our heart. About 90% classmates, everybody is correct. Okay, let me explain this to you. Since I'm an electrophysiologist, I will explain some basic mechanism of ion channels to you. We have three basic types of ion channels on our cell membrane, include not only myocyte, also include our neurons, our other myocytes, and our gastrointestinal tract cell. And the three basic channels include a voltage gate channel, ligand gate channel, and tension gate. And what is a voltage gate ion channel? Channel is composed of protein, and the protein is charged. Since the protein is charged, if the membrane potential change, and the shape of the protein will change, and the channel will open or close. This is the basic mechanism of voltage gate channel. So you can see that most of the ion channel is closed at the negative membrane potential inside, but when the membrane potential is positive inside, that means depolarization, the ion channel open. And ligand gate means something bind to the channel and the channel will open. And tension gate is easy to understand when we stretch the membrane and the ion channel open. And all this we call ion channel must, the ion movement across the channel must be free, and it's according to the concentration gradient, not against the gradient. We can see that there are many ways of ion movement on our cell membrane of the cardiomyocyte, include the potassium channel, chloride channel, calcium channel, and the sodium calcium exchanger, and the sodium potassium ATPase. From our previous lecture, we already know that sodium potassium ATPase restore intracellular sodium potassium level and reset, and also keep the resting membrane potential. Let me ask myself a question. Let you ask yourself a question. Is sodium potassium ATPase an ion channel? I just said that ion channel must provide free movement of the ions according to the concentration gradient. But for sodium potassium pump, first, it needs to use energy. It needs use ATP. And the second, it's not free movement. It uses 3 intracellular sodium to exchange for 2 extracellular potassium. So it's not free movement. It uses energy, so it's not an ion channel. These are not ion channels, include sodium, potassium, ATPase, include sodium calcium exchanger. These are not ion channels. Then I will review the action potential to you. This is the action potential of our heart. At phase 0, when the cell membrane depolarizes from -80 to positive, the sodium channel open. And then there's a transient inward current of the potassium current. So the membrane potential decrease a little bit. And then the calcium channel open. There's an inward current of the calcium to keep the resting membrane potential around 0 and 10. And then the calcium channel close. So there's only potassium outward current, the efflux of the potassium. So it restored the resting membrane potential to -90. At phase 4, there's a background, we call it KIR. There's a background potassium current to keep the resting membrane potential at -90. And for our human heart, the action potential is a little bit different between atrial and ventricular myocyte. You can see that for atrial myocyte, the action potential duration is shorter than ventricular myocyte. And why? Because there's an ion channel expressed more in the atrium than the ventricle. We call it IKUR, ultra rapid, very fast potassium channel. Since its potassium channel is an outward current, so it shortened the action potential duration. It's outward. Potassium outward is more than for the atrium than the ventricle, so the action potential is shorter for the atrium. Okay, that is the action potential. But how does action potential connect to our cardiomyocyte contraction? And the question is, which stage is the contraction stage during the action potential? Please vote. Phase 0, the sodium efflux. Phase 1, the sodium current inward sodium. And phase 1 is outward potassium. Phase 2 is inward calcium with outward potassium. And phase 3 is outward potassium. And which one is the contraction stage? Okay, interesting. Please vote. Let me know your response. Somebody say phase 0, somebody say phase 1, somebody say phase 2. Here is our result. I think somebody think that a sodium channel is related to the contraction, and somebody says phase 1, somebody say phase 2. Okay. Which ion is the key ion for the myocardial contraction? Actually, it's calcium, not sodium, not potassium. Sodium channel is responsible for the conduction of the signal. Potassium channel is responsible for the membrane potential, and the calcium channel is responsible for the contraction. I will explain a physiology we call the calcium-induced calcium release to you. At resting status, there's a lot of calcium stored in our myocyte in the SR, sarcoplastic reticulum. The calcium is shown here in the red spots. And at phase 2, when the extracellular get inside the cardiomyocyte from the calcium channel, the extracellular will activate a receptor. We call it ryanodine receptor 2, RYR2. This receptor will open and the calcium stored in the SR will release. So the extracellular calcium induce intracellular calcium release. So we call it CICR. This calcium will interact with our myofilament to make our myocyte contract. Then at the relaxation stage, our pump, there's a pump called Circa, will pump the calcium back into the myocyte, back into the SR. And also the NCX and the calcium pump will pump some calcium out of the cell. So this is at the relaxation stage. And how does the myocyte react with the myofilament? Why does the calcium react with the myofilament? We can see that there's a group of protein called the troponin. Troponin is bind to the tropomyosin and bind to the actin. At resting stage, the troponin C means calcium, troponin T, troponin I means inhibition. This troponin will inhibit interaction between actin and the myosin. And when at phase 2, the calcium released from the SR, the calcium will bind to troponin C. The calcium bind to troponin C and the tropomyosin shape will change and tropomyosin will move away and express this actin myosin binding spot, and myosin will bind to our actin, and then after the binding, the myocyte can contract. So this is the basic mechanism we call EC coupling, exciting contracting coupling. Okay. So our myocyte contraction happened at phase 2, at the plateau phase. And the bottom figure is the ECG. So the contraction phase actually is at the ST segment, shortly after the QRS. QRS means the signal conduction through the ventricle. And after the conduction, the myocyte contract at the ST segment. Okay, here is the next question. Our heart never stops, right? Because we are here, we are alive. And what is the energy source of our heart? Our heart uses glucose, use fatty acid, use ketone body, or we can use all above as the heart energy. We know that our brain uses glucose only because in the skull, in our head, we cannot store any energy inside. So our brain can only use glucose as their energy. And how about our heart? Okay, my teacher always teach me that if you show a choice is all above, pick this one, you have more than 50% chance to be correct. So the correct answer is all above. Okay, let me show you. This is the energy source of heart because our heart beat all the time. So our heart takes everything it can. But as the resting stage, the main fuel source for the heart, remember, is fatty acid, supplying about 90% of the energy. But when the heart beats faster, it needs everything. So we can also use glucose. We can use ketone body as the energy for our heart. So our heart is every energy in the blood. So our heart takes only 3% of blood from the left ventricle to the coronary artery. But actually, because our heart is fully aerobic breathing, aerobic metabolism, so there's a lot of mitochondria in our cardiac myocyte. So actually, our heart can use like 11% of oxygen of our total O2 consumption. Okay, then we move to the conduction system. The learning point here, I will show you why do we need a conduction system, the anatomy of our conduction system, and also the difference of action potential between pacemaker cells and cardiac myocyte. So let me ask you an interesting question. Everybody please take a little break and feel your heartbeat on your chest wall. When you palpate your chest wall, you will feel your heartbeat, right? And here is my question. When you feel your heartbeat, when you feel the impulse, is the impulse at systolic phase or the diastolic phase? An interesting question, because some of my students think that the heart shrinks when it contracts. So the heart expands when it diastole. So when you feel the heart is at the diastolic phase, is this reasonable or not? Is the pulse at the systolic phase or diastolic phase? Or you can also choose I don't know or I don't care, because I don't know who you are, okay? This is a really interesting question. So when you learn anything, everything, you need to try to find unreasonable, if anything is unreasonable, you cannot explain, and you need to find the answer by yourself. Just like this. So some of my students will change their answer because I told them the heart expands when at the diastolic phase. Okay, let me show you. Here is our result. You can see that about 1/3 of our students choose the diastolic phase when we feel our heartbeat. But actually, the correct answer is the systolic phase. Why? The arrangement of our ventricular myocyte is not that simple. It's not unidirectional. It's like a spiral. So when our left ventricle contract, actually it's like a spiral motion toward our left ventricular apex. So the total force is toward the apex, and there's a rotation, not only shrink. So just like we squeeze our tower, our right hand and left hand force at different direction. So the point is that our ventricular myocyte needs to work together, not one by one, not from left to right or from right to left. Every myocyte needs to work together. To make every myocyte work together, so we need our conduction system, because the signal travels very fast in our conduction system. And if we don't have any conduction system, the signal travels very slow. So the myocyte contract one by one if we don't have conduction system. So the conduction system of our heart is composed of a sinoatrial node. It is located at the junction between the superior vena cava and right atrium. And we have an AV node, we have a His bundle, then we have right fibers and left fiber go to the right and left ventricle. And we also have a bundle, we call it Bachmann bundle. Bachmann bundle conduct the signal from the right atrium to the left atrium to make two atrium contraction at the same time. Okay, then here's the next question. Where does the signal of our heartbeat start from? Is the signal start from our brainstem, or from the SA node, or from the AV node? Most of the time, we don't need to think about heartbeat, right? I don't need to command my heart to jump, and I can not stop my heartbeat by my will. So I think this question is quite easy, right? Our heartbeat start at SA node. So I think most of our students already know this. Okay, but behind this, SA node is the chief commander of the heart. It starts the impulse and the heart contract. So it's just like the power plant of our heart. And AV node is just like a bridge between the atrium and ventricle. You can see this is only connection between our atrium and ventricle. And the left bundle, right bundle, and these fibers, Purkinje fibers, act as the wires to conduct the signal very fast through our left and right ventricle. So the heart can work together, the ventricle can work together. And why does our SA node generate impulse? This is the action potential of our SA node. It's different from the action potential of other myocyte, right? Which part is different? There's no sodium channel at phase 0. You can see that there's no sodium channel, no sodium current. Why not? Because I just said that sodium channel is responsible for the signal conduction, not signal generation. SA node is the chief commander, so actually the SA node does not need to conduct the signal. It just needs to generate the signal. So we don't use any sodium channel on the SA node. Instead, we have a very interesting current on the SA node, which is not on the other myocyte. We call it IF. We call it funny current because it's funny. And why it's funny? Because it's hyperpolarized activate. When I show you the ion channels in the previous session, I told you that usually the ion channel, voltage gate channel open when the membrane potential become more positive. But for the funny current, it's totally different. It's opposite. When the resting membrane potential become negative, it open. And sodium and the potassium can move across the channel, and there will be a net positive inward current. So the resting membrane potential will gradually depolarize to -30, and the calcium channel open, and there's action potential. And this is the impulse of our heart, and the signal then travel through the AV node to our ventricle. So this is why the SA node can generate an action potential by itself, because it has an important current called funny current. Okay, the next session I will talk about the cardiac output. It's getting more and more difficult. The main point here include what are the factors that affect our cardiac output, and how much blood flow and oxygen does the normal heart deliver, and then how much O2 do we need at rest. Okay, what is the average volume at rest of a normal heart? The stroke volume is 30 ml, 70, 120, and or 160 for a human heart. Okay, I think there are two answers very close, 100 ml or 70 ml. Which one is correct? Come on, give me some response. Okay, the correct answer is 70. I don't have too much time to wait, sorry. Our stroke volume, our amount of blood that each heartbeat can deliver is called a stroke volume, equals to the N diastolic volume minus N systolic volume. And our cardiac output equals to the heart rate times the stroke volume. Every normal human, we can deliver about like 60 to 100 ml of blood each beat. So the stroke volume is like this. But actually, you know that we have very big and fat guy, and we also have very thin and small guy. So we need to know the relative performance of the heart. So sometimes we don't use the stroke volume, we use stroke volume index. That is the stroke volume divided by our body surface area. We use the body surface area to represent the relative performance of the heart. And what are the factors that affect our stroke volume, our heart performance? Include the contractility, the preload, and afterload. These three factors are the important factors which affect our heart performance. Let me explain the preload and afterload here. The preload is the amount of ventricular stretch at the end of diastole when the heart expands. So we call it left ventricular end diastolic pressure. And afterload is the amount of resistance that heart must overcome to open the aortic valve to squeeze the blood out into the aorta. So it's called a systemic vascular resistance. I'll explain here with a spring, a coil. What is preload? When we try to elongate the coil, when we try to pull the coil. And what is contractility? Is the force of recoil of this spring jump back to its original condition. So increased preload and increased contractility both are good for our cardiac output, for our stroke volume. And what is systemic vascular resistance? The systemic vascular resistance, just like the force that against the aortic valve open. So when the heart contracts, first of all, it must open the aortic valve, then the blood can go out into the aorta. And the resistance is negative to our stroke volume because the more the resistance, the left ventricle is more difficult to pump out our blood. And I think most of you here heard about this. What is Frank-starling law? When we elongate our cardiac myocyte, and it will get more force to recoil, right? So when we have more preload, our cardiac output also increase. And when we pull the myocyte more and elongate more, and there's a certain point that the contractility does not improve at this point, then our cardiac output becomes same, then it goes downhill because we pull the cardiac myocyte too much and it gets damaged. So if a patient gets heart failure, this is the curve of different Frank-starling line for normal heart, for heart failure, and for exercise. For a patient with heart failure, the curve moves downward. And if we exercise, we have more sympathetic tone and the contractility will increase. So the curve moves upward. This is called the Frank-starling law. Okay, then I will explain the cardiac output. Cardiac output equal to the heart rate times stroke volume. Usually our heartbeat is around 70 per minute, and our short volume was, I showed you, is around 70. So the cardiac output is close to 5 liters per minute at rest. So this is our cardiac output. And to show the relative cardiac performance, we use cardiac index. That is cardiac output divided by our total body surface area. That is relative cardiac performance. And usually the normal range is 2.5 to 4. Okay, why do we need a circulation system? To supply oxygen and nutrition and to remove the waste, right? So actually our circulation system is like a railroad system. The blood vessel is the rails. The engine is our heart. The cabin is hemoglobin. And something the hemoglobin carry is oxygen. Okay, here's the question. How much oxygen can we deliver at rest? Our heart delivers about 1,000 ml of oxygen per minute, 2,000, 3,000, of only 500 for a normal heart. Okay, I think most of you already know the answer. It's good. It's like 1,000 ml O2 per minute. Let me calculate. Let me use this formula to calculate. The delivery of oxygen equals to the cardiac output times 1.4. 1.4, that is the oxygen binding capacity. Usually a gram of hemoglobin can carry 1.4 ml of oxygen. And times the hemoglobin, the concentration of hemoglobin, and times the O2 saturation in our blood, and the plus the oxygen that dissolved in the blood. Usually the PaO2 is 160, so 160 times 0.003 is less than 1, so this one is too small and we can ignore. So to make it simple, delivery of our O2 equals to the cardiac output. It's 5L per minute, so it's 50 deciliter per minute, times 1.4, times our hemoglobin usually is around 15 gram per deciliter, and times the O2 saturation, usually 97 to 98. And pick up your calculator and calculate this. Okay, the number should be very, very close to 1,000. So our heart delivers 1,000 ml of oxygen per minute. And this is O2 delivery. And what is O2 consumption? I think most of you have experienced doing some exercise and heard about 1 MET. MET is metabolic equivalent, and 1 MET is defined as the amount of oxygen that our body consumes at rest. And 1 MET is equal to 3.5 ml of oxygen per kilo body weight. So for me, I'm a male with 71 kilogram, and my O2 consumption at rest is 3.5 times 71, my body weight. So it equals 249. So I deliver 1,000 ml O2 per minute. I use 245 ml O2 at rest. So my O2 consumption ratio, my O2 extraction ratio at rest is close to 25%. So this picture is the summary of the O2 delivery and O2 consumption. Usually for normal adult people, we deliver 1,000 ml of O2 per minute, and at rest, we use only 250 ml. So our O2 extraction ratio is around 25% at rest. But if we perform an exercise like 5 MET or 6 MET, then although our delivery of O2 also increased during exercise, but if we do a very vigorous exercise like 10 MET, definitely the O2 will be not enough for our body. So our muscle can use glucose as anaerobic metabolism. That is, the glucose become pyruvate and become lactate. And the lactate will accumulate in the muscle, so we feel muscle pain, soreness during exercise. Then the lactate go back to our liver to become pyruvate again. This is anaerobic metabolism when our O2 is not enough for aerobic metabolism. Okay, then we go to the next session. We go to the cardiac cycle and heart sound. And in this part, the learning point include the cardiac cycle and pressure volume loop. Where do the normal heart sound come from? And what do third and fourth heart sound mean? Here is the cardiac cycle. And left side is the cycle of the heart, and right side is the pressure curve for the aorta, for the left ventricle and left atrium. We start from point A. Point A is after the P wave on the ECG. So it means the atrial systole. The atrial squeeze the blood into the ventricle. And after that, the signal go to the ventricle and start a ventricular contraction, right? So at the beginning of ventricular contraction, the pressure in the left ventricle is still below the pressure in the aorta. So at stage B, actually the aortic valve does not open yet. So we call it isovolumic contraction because the volume inside the ventricle does not change because the pressure is still below the aorta. And at this point, at this red line, when the pressure of left ventricle goes above the pressure in the aorta valve will open here. Then the heart pump out the blood to stage C. So its ventricle actually is the systolic phase of the ventricle, the true systolic ejection phase of the ventricle. Then our left heart starts to relax, to expand. So at the diastolic phase, the pressure going down gradually. When the pressure goes below the aorta, the aortic valve then closes at this point. So after this point, the cycle moves to D. D means isovolumic relaxation, because although the left ventricle starts to relax, but the pressure inside the left ventricle is still above the pressure in the left atrium. So the mitral valve cannot open because the pressure is higher in the left ventricle. Then our left ventricle keep relaxing to this point. This point, the left ventricle pressure fall below the left atrial pressure. So at this point, at this red line, the mitral valve open. Then we go to the left ventricular filling time. So the blood go into the left ventricle from the left atrium. So this is the cardiac cycle, include the isovolumic contraction, the ejection phase, then the isovolumic relaxation, and the filling phase. And this is a little bit difficult, and this is the pressure volume loop. The pressure volume loop is relatively difficult to understand, but I will still explain to you. Before I explain, which segment represent the isovolumic contraction I just talked about? Segment B, C, D, or A? You see that since this is isovolumic, so the segment, at the segment, the volume must remain the same, right? The x-axis is the volume. So this segment, during this segment, the volume does not change. The only change is the pressure, right? And also it's the isovolumic contraction. So it's just before the contraction. So the volume must be larger. Because I will show you the pathophysiology of heart failure in the next session. So everybody must understand this pressure volume loop. Then we can moving forward. Okay, let me show you the response. Okay, the correct answer is B. I will explain it here. At point A is here. It's just before the ventricular contraction. When the ventricle contract, the pressure raise and close the mitral valve. So point A is close of mitral and tricuspid valve. And after point A, the ventricle keep contracting, but the pressure is still below the aortic pressure. So will the aortic valve open during this segment? No, it will not, because the pressure is lower in the ventricle. And the ventricle keep contracting from point A contracting to point B. So you can see that left ventricular pressure raise because the ventricle contracts. Then to point B, finally the pressure is above the aortic pressure. Finally, the aortic valve open at point B at here. So after point B, there's ejection phase. We can pump out the blood into the aorta from the ventricle. So segment B to C, we call it true ejection phase. Then at the top of the pressure, the left ventricle start to relax to the diastolic phase. So the pressure gradually decrease. When the pressure of the left ventricle is below the aortic pressure, what will happen? The aortic valve will close at point C. Then the left ventricle keep relaxing until the pressure is below the left atrium. So until the mitral valve open here. Segment between C and D means the isovolumic relaxation. The pressure keep moving down, but the volume does not change. Okay. I think some of you already have a stethoscope and can hear your own heart sound. For normal people, we have two heart sounds, S1 and S2. Dun, 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 dun. So point A, B, C, and D. Which spot where you hear the first heart sound? Point A, point B, or point C, or point D? Okay, the correct answer is point A. Let me show you the cause the ETR. Why do we have two heart sounds? We have in normal adults we have first and second heart sound, S1 and S2, dong 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 dong, and S1 is produced by the close of the AV valve, includes mitral and the tricuspid valve, and S2 is produced by the closing of aortic and pulmonary valve. So here is the relationship between our heart sound and the pressure. S1 is produced by the mitral valve close. So which point mitral valve close? Here, right? I just show you when the pressure, when the left ventricular pressure raised above the left atrial pressure, the mitral valve will close. So at this point A, we will hear S1. And then S2 is produced by the closing of the aortic and the pulmonary valve. So where does aortic valve close? It's at the point where the left ventricular pressure fall below the atrial pressure. So it's at here. So here we can hear S2. And then what is the third heart sound? The third heart sound is thought to be caused by the oscillation of blood between the walls of left ventricle, initiated by blood rushing in. It's a little difficult to understand. Just show that it's caused by the rapid ventricular filling. When the blood rushes into the left ventricle from the atrium. So usually it means we have a status called volume overload, have more blood in our atrium and ventricle, and we can hear S3. So usually S3 may be benign in some young people, in athletes, and in pregnancy mothers, but also can be here in some pathological status, such as patients with heart failure. I will explain the pathophysiology of heart failure in the next session. And S4, the fourth heart sound, is produced by the sound of blood being forced into a stiff ventricle. To make it short, you just remember it's produced by an atrial kick, atrial contraction. So it usually means the pressure overload in the left ventricle. So S4 is a sign of an aging heart. It's a pathological status, and we can hear S4 on patients with hypertrophic left ventricle, such as patients with very serious hypertension, severe aortic valve stenosis, or hypertrophic cardiomyopathy. And where can we hear S3 and S4 in our cardiac cycle? So I just show you that S3 is produced by rapid ventricular filling. So after the mitral valve open at point D, then we start ventricular filling. So S3 must at this point after the mitral valve open. The mitral valve open here, then we can hear S3 here. And S4 is produced by atrial kick, produced by atrial contraction. So it's just right after the P wave of the ECG and also just before the ventricular contraction. So it's over here and the pressure volume loop is over here because point A ventricular contraction starts. So we can hear dolo, 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 dolo. Sometimes patients with heart failure will have four heart sound, dolo, 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 just like a horse running. Okay, I think in the session one, we talk about the normal physiology of the heart. If you have any question, if you are not understanding my point very well, and if you are too shy to talk, and you can put numbers here in the chat, and I will try to explain to you here. And let's take a break for like 10 minutes. Okay. Okay, everybody be back in 10 minutes. If you have any question, you can type in the chat. Okay, everybody, please come back. We'll start in a minute. Okay, I think the break is should be stopped here. I need to start the next session. The next session, I will talk about some pathophysiology of our heart, the diseased heart, and also the diseased circulation system. And just also take it easy. Don't be stressful because you are not facing your patients right now. And if you have anything that you don't understand very well, you can ask in the chat session. Okay, then we move to the second part one, heart failure. That means our heart cannot pump out our blood effectively. And the learning points here include the diagnosis and types of heart failure, the virtuous cycle of heart failure, and also the simple management of heart failure. Okay, please react with this question. What is or what are common symptoms of a heart failure? This is important because some of friends or some of your relatives, your family members will ask you this kind of question. Is my heart good? Do I have heart failure? So, okay, I should not put the answer all above. I think everybody else choose the all above. Okay, the correct answer is all above. Right, you are right. All these symptoms can be happen on a patient with congestive heart failure. These are common symptoms of heart failure, include shortness of breath, include the ankle swelling and feel fatigue, lack of energy, and difficult to sleep, difficult to lie down. And also some people will have cough or increased urine at night. And this is the definition of heart failure according to European Society of Cardiology in 2016. So actually, heart failure is a syndrome characterized by typical symptom and sign caused by a structure or function cardiac anomaly. Our heart cannot pump out blood very well. So a patient will feel breathless, orthopnea, and also paroxysmal nocturnal dyspnea. That means you wake up at night and feel very difficult to breathe, and reduced exercise tolerance, fatigue, and ankle swelling. So heart failure includes a group of symptoms when your heart does not function very well. And the severity of the heart failure can be separated to 4 classes. So class 1, that means although your heart is not good, but there's no limitation of any physical activity. You can run, you can climb stairs, don't have any symptom. And functional class 2, your physical activity is slightly limited. You can walk, but when you run, you feel easy to have a dyspnea or shortness of breath. You cannot run very well. And functional class 3 means marked limitation of physical activity. Even if you walk for like 50 or 100 meters, you feel shortness of breath. So it's marked limited of physical activity. And functional class 4 means you have symptoms at rest. When you sit down, you may feel shortness of breath. You cannot lie down. So this is more serious class. It's functional class 4. And clinically, there are many causes of left heart or right heart failure, include heart attack, which you call myocardial infarction, include hypertension, diabetes, any arrhythmia, serious arrhythmia, valvular heart disease, and congenital heart disease, such as ASD, VSD, and you have kidney failure. We have cardiorenal syndrome or hyperthyroidism or certain kind of bacteria or viral infection that cause myocarditis, such as COVID-19. Severe patient with COVID-19, there's 20% chance to have myocarditis and heart failure, and also cardiomyopathy, some mutation of the myocyte, so the heart cannot contract very well. So we go back to pressure volume loop. Pressure volume loop is always about pressure volume loop, so it's really important for our cardiologists. We just talk about pressure volume loop. At this point, just before the myocardial contraction, we call this end diastolic volume at this point. And this point, we call it end systolic volume over here. So the difference between end diastolic volume and end systolic volume, what is it? It's our stroke volume, right? So the difference at x-axis is our stroke volume. And end diastolic volume here is the preload end diastolic volume. It's usually equals to the end diastolic pressure. And then the artery valve open. If the artery pressure is very high, then the left heart needs to make more force. So the artery valve open at higher spot. So this spot is the afterload that our left ventricle face. And where is contractility? There's a red line over here. This is called as ESPVR. We call it end systolic pressure volume relationship, ESPVR. This can represent our contractility of the heart. It's relatively very difficult to understand. Let me explain this. Let me show you the ESPVR and the stroke volume. So there are two pressure volume loops, loops 1 and loop 2. Loop 1 is our resting status, loop 1 over here. And this is the stroke volume of the loop 1. Okay, with the same preload at this point, with the same afterload at this point. But if we do exercise, if our sympathetic tone raise, so our heart contract more powerful. So the ESPVR1 become ESPVR2. The slope of ESPVR will increase. Then, even with the same preload, same afterload, but the stroke volume increase because our heart contract more powerful. So the artery valve close at this point. So we have more stroke volume. So ESPVR can represent the contractility. If ESPVR slope increase, stroke volume increase. On the other hand, if the ESPVR decrease and the stroke volume decrease. So for heart failure, our ESPVR decrease, the contractility decrease. Here, I will explain to you acute heart failure versus chronic heart failure. Acute heart failure means that we have a heart attack. Our left ventricular function decrease very fast, suddenly decrease. So with acute heart failure, your preload, your afterload does not change a lot, but your contractility decrease rapidly. So because of the slope change, then your artery valve will close at this spot instead of this spot. So if your artery valve close here, then what will happen? then your loop will close here. Then this will be your new strobolen. You can see that this is your original strobolen, this is your new strobolen. So you have a very low cardiac output, it's very dangerous. So this is called acute heart failure, usually by sudden condition such as myocardial infarction. But some people have a relative chronic heart failure. If you have a mitral valve regurgitation, if you have other myocarditis, the heart failure happens step by step, then your heart will not surrender. Don't worry. Your heart, your left ventricle will dilate, will expand to compensate the decrease of contractility. So although the ESPV are decreased here, you can see the dotted line here. Your heart dilate. Both of your end diastolic and end systolic increase. So you can keep the same strobolen at this contractility, at this ESPVR. So this is called the chronic heart failure. Your heart gets bigger, but you can keep similar strobolen and you will not die. And for diastolic heart failure, this is systolic heart failure, the contractility decrease, so your heart systolic function is not good. But some people have a relative stiff heart. That means the compliance of the left ventricle decrease. As the compliance decrease, so the pressure in the left ventricle increase. So although people with diastolic heart failure have very similar strobolen, but the pressure in the left ventricle increase. So the pressure in the left atrium also increase, and the pressure in the pulmonary vein also increase. So you also feel dyspnea, but your cardiac output remains the same. So don't worry, for diastolic heart failure, the prognosis is not that bad. Okay, let me explain it with the Frank-starling law again. When you have chronic heart failure, your systolic function decrease, your ESPVR change, then your heart gets bigger to compensate. The loop change from here to here, your heart dilate. The Frank-starling law at this point remains the same, so the cardiac output remains. But as time goes by, your ESPVR decrease gradually to this point, and your heart dilate more. And Frank-starling law start to getting downhill. So your cardiac output will decrease. So people will die of heart failure when heart failure get worse. So this is actually a virtuous cycle. Your heart dilate and dilate, but the space in your chest is fixed. The heart cannot dilate unlimited. So people will die of low cardiac output. So this is the first virtuous cycle. And I will show you another virtuous cycle of heart failure. It's more difficult to understand. Don't worry, take it easy. This is our kidney, not our heart. This is our nephron, not myocyte. And you can see that at the distal convoluted tubule, very close to the Bowman's capsule, there's a group of cells, we call it macula densa. You must learn it in your histology lesson. Macula densa is just like the doorway, the gate of the Bowman's capsule. It can control the blood inflow and outflow from the afferent and efferent arteriole. So it can modulate the pressure inside the Bowman's capsule. Just take a breath. Think about like thousands or 10,000 years ago. When we are in Stone Age, when we are facing animals, we need to hunt for life. We face disease such as bleeding, such as infection, such as dehydration. At these circumstances, the blood pressure will decrease, and our kidney, our glomerular filling pressure will decrease. So our glomerular filling pressure decrease, our urine decrease, so our waste, we cannot remove the waste in the blood from the urine. So it's not good, we will die. But we do not surrender. We have a good feedback system. We call it tubular glomerular feedback. When the GFR decreases, the macula densa sense that we are dehydrated because the sodium in the urine also decrease. Then we will act this feedback system. The macula densa will secrete something to make afferent arteriole dilate and efferent arteriole constrict. So the pressure inside the Bowman's capsule increase. So our GFR will raise. We will have more urine. We can remove the waste. But you may ask me a question. Since we are already dehydrated, we have more urine. That means more dehydrated, right? No, not right. No need to worry because this feedback is perfect. At the efferent arteriole side, we secrete renin. Renin will stimulate our pituitary gland to secrete a hormone called antidiuretic hormone. This ADH can keep water in our collecting duct in the kidney. And also angiotensin II is an endogenous vasopressor. It constricts our small vessels and raises our blood pressure. And also angiotensin II can stimulate our adrenal gland to secrete aldosterone. Aldosterone is a hormone that keeps sodium and removes potassium and hydrogen in the urine. So it's perfect. We can remove the waste. We can keep the water. We raise our blood pressure and sodium. The perfect feedback. But thousands years later, 10,000 years later, we have a new disease called heart failure. And for heart failure, we call it cardiorenal syndrome, and the GFR also decrease, and we start the feedback, and we keep the water and keep the sodium, and more water in the blood, the left ventricle dilate more, and the blood pressure drop again. So this is a second vicious cycle of our heart failure. Okay, to face this vicious cycle, to break this vicious cycle, what are the treatments? What are the drugs that we can treat our patient with chronic systolic heart failure? Please vote. Everybody, please choose what? Choose anyone. Okay. I think it's maybe too difficult in the second part. There are only 19 people vote. Don't worry, when you see an answer call all of above, just pick this one. You have more than 50% of chance to be correct. Okay. Everybody is correct. All of above drugs can treat heart failure. Diuretic can remove the excess water and sodium in the blood, so the left ventricle will not keep dilating. And the beta block can reduce the afterload, can reduce the blood pressure and slow down the heartbeat. Because long-term sympathetic stimulation is not good for our heart, the beta receptor will downregulation. So we need to make our heart rest, use less energy. So we use beta blockers. And then we also use drugs such as converting enzyme inhibitor, and angiotensin receptor blocker, and mineralocorticoid receptor antagonist. These drugs will block the renin-angiotensin system and block the tubular glomerular feedback I just talked about. And there's a new class of drug called the neprilysin inhibitor. This class of drug, we have a drug called Entresto. Actually, it's a ARB plus a neprilysin inhibitor. Actually, humans have an endogenous diuretic. We call it nitriuretic peptides. We have AMP and BMP secreted by our heart. When our intracardiac pressure raises, the heart will secrete AMP, BMP to remove the excess sodium and water from the kidney. So the AMP, BMP actually is the endogenous diuretic, and the neprilysin inhibitor can increase the concentration of endogenous AMP and BMP. So when you come to the hospital, you go to the hospital 2 or 3 years later, you have a basic concept of heart failure, and you can face our patients. So next, I will talk about a serious situation we call shock. In this part, the learning point include why do we need blood pressure? What is the definition of shock? And what are the types of shock? Interesting question. What is the average systolic blood pressure of an adult giraffe? Please guess. 150, 200, 250, 300. This is the blood pressure for a normal human being. It's around 120 and 80. But for giraffe, what is the normal blood pressure? Okay. The correct answer is 250 to 300. So why do we need blood pressure? Why do giraffes need such high blood pressure? Because the blood pressure is used to perfuse our organ. Although blood pressure, we call it SVR, is not good for our heart, because if our blood pressure is very high, then the afterload is quite high. So our left heart is not easy to pump out the blood. But we still need our blood pressure to perfuse our organ. So when you stand up, when you are at standing position, which organ is the most difficult to perfuse? Of course, it's our brain. Our brain takes about 15% of blood from the left heart. But you can do an interesting experiment. If you have a blood pressure machine, can check your blood pressure. First of all, you sit down and check your blood pressure at the left arm. And this is my blood pressure, 190 and 83 at this level, at heart level. But sit down and raise your left arm to the level of your head like this. Raise your left arm and then press the measurement again. You will find that your arm at this level, the blood pressure is around 93. It's around 25 to 30 different between your brain level and your heart level. So for giraffe, the height is usually like 2.5 to 3 meters. So the giraffe need a very high blood pressure to perfuse their brain. So for human, what is the perfusion pressure necessary for our brain perfusion? The brain perfusion, to make a stable brain perfusion, we need a blood pressure above 60 mmHg. That we call the cerebral perfusion pressure. It equals to a mean arterial pressure minus intracranial pressure. For normal people, the ICP is around 10 mmHg. So our mean AP should be above 70 mmHg. If it falls below 60, the auto-regulation will not functioning very well. So our perfusion to the brain will decrease at this point, and you will lose your conscious. For heart, it's also very interesting for the perfusion. Our coronary arteries is growth on the surface of our heart. Why? Why it's not inside of our heart? Because when our heart contracts, the pressure inside the left ventricle increase. So all the vessel will be compressed. There's no perfusion in the deep endocardium here. and the perfusion at the epicardium remains the same. And at diastolic phase, when the left ventricular pressure decreases, so the endocardium can be perfused better. That is why the coronary artery need to grow on the surface of the heart instead of inside our heart. So we need blood pressure to perfuse our organs. So what is the definition of shock? What is the definition of shock? Is it a blood pressure below 90/60, low blood pressure, the nurse call you or the patient gets shocked, or the systemic tissue hypoxia, the patient have less urine and conscious disturbance, or sudden loss of consciousness when you suddenly hear some unpleasant event? Of course, it's not answer C. Okay, the correct definition is answer B. The shock is defined by a critical condition that is brought on by a sudden drop in blood flow. Actually, sudden drop in blood flow, but there's no actual number. The shock means the circulation system failed to maintain adequate blood flow, sharply curtailing the delivery of oxygen and nutrient to vital organs. So with a shock patient, we usually need to take care of this patient in the intensive care unit in our ICU. And we will put some catheters to monitor the hemodynamic parameters on these patients. So I will show you two parameters that we may measure on this patient with shock. The first parameter we monitor, we call the CVP, is the central venous pressure. The waveform of the CVP include A, C, X, V, and Y. The catheter is put inside the body via the left subclavian vein or the left jugular vein, and the tip will stay in the superior vena cava or the entrance of the right atrium. And what are these waves mean? A, C, X, V, Y. The A wave means you see that the A wave is just after the P wave on the ECG. So the A wave actually means the atrial contraction, because the CVP equals the right atrial pressure. So when right atrial contraction, there's a waveform called A wave. Then after atrial contraction, there's atrial relaxation, so the pressure going down. But then the ventricle contract, the right ventricle contract. So when right ventricle contract, the tricuspid valve will close. When tricuspid valve close, there's a rebound of the right atrial pressure. We call it C wave. Then the right atrium keep relaxed, so the pressure keep going down. Then the blood come back to the right atrium from the SVC, from the IVC, from the other veins of our body. So there's atrial filling. So the pressure in the right atrium raise. We call it V wave. And after that, the ventricular relaxation, the tricuspid valve and mitral valve open. So the blood go into the ventricle from the atrium. So the pressure in the right atrium decrease to Vy point. So this is the basic waveform of the CVP. You don't need to remember this, just need to know what this waveform means. So why do we measure CVP? CVP can represent the preload of the right heart, also can represent the volume status of our body. Another hemodynamic monitor that we may measure when people get shocked is we call the PCWP, pulmonary capillary wedge pressure. How to measure this wedge pressure? We put a long catheter from the SVC to RA to right ventricle to pulmonary artery, and the tip of the catheter will stop in a branch of pulmonary artery. There's a small balloon at the tip of the catheter. When we inflate, when we expand the balloon to occlude this branch, the vessel, because there's no blood flow, so the pressure will be same at two sides of the heart, will be same here to here. So the pressure here means the left atrial pressure, also means the left ventricular and diastolic pressure. It sounds familiar. Why? Because it can represent the preload of the left ventricle. LVEDP means the preload of the left ventricle. So we use PCWP to monitor the preload of the left ventricle. But in certainly ill patient, the patient may get respiratory failure and be intubated with ventilator, such as COVID-19 infection. Serious patient get intubated. When we breathe, we use negative pressure to drive the air into your lung. But when patient get intubated, there's positive pressure to breathe. It's different from our spontaneous breathing, right? So the machine delivers positive pressure to the lung. So the positive pressure will compress our vessel in the lung. So if we measure the pressure, we also will measure the pressure at this point. So it's not accurate to measure PCWP. So if the patient gets intubated, and if we really need to measure this PCWP, we need to transiently stop the positive pressure in the ventilator to turn off the positive pressure. Then we can measure the PCWP. Okay, so when you become a real doctor, you need to take care of the shock patients. When you face a shock patients, first of all, you need to know the etiology, why the patient gets shocked, because the management is quite different. The main types of shock include the cardiogenic shock. That means I just talked about heart failure. Your heart cannot pump out the blood. You got myocardial infarction, heart attack. You got cardiogenic shock. And some people have large amount of gastrointestinal bleeding, GI bleeding, and some patients get dehydrated, so the patient get hypovolemic shock. That means the blood volume decreased, so you cannot deliver the oxygen. And some people get septic shock. It's caused by bacterial infection. We know that sepsis is the life-threatening organ dysfunction due to a dysregulated host response to infection. Usually, our immune response is used to defend our body to remove this bacteria or virus. But sometimes our immune system is overreacted on some certain toxins the bacteria produce. So these endotoxins will cause our vessel dilatation. Our small vessel or capillary dilate. So even if we have enough blood volume, but think about that. This blood go to the distal circulation, to the capillaries, to some skin and the muscle and the adipose tissue, but we don't need a lot of blood flow there. And if you redirect this blood flow to our skin, our muscles, the perfuse of our vital organ decrease. The perfuse to our brain, to our kidney, to our GI tract decrease. So the perfusion pressure decrease because of redistribution of the blood volume, because of systemic vasodilatation. So when people get septic shock, you won't feel the patient so cold. The patient is warm and even get fever. So septic shock is called warm shock. And I just told you that we need to monitor the preload of the left ventricle and the CVP to evaluate the treatment response of our patients. For these different kinds of shock, this parameter will change. For hypovolemic shock, it's caused by dehydration or large amount of bleeding, so the preload must decrease. The RA pressure, we call the CVP, and the pulmonary pressure will decrease. Our cardiac index may decrease or remain similar, but because our volume decrease, our sympathetic tone raises. So actually our distal blood vessel will contract. So actually the resistance increase. So the shock is due to volume decrease. So the treatment is volume expansion. It's the easiest management of this kind of shock. We give the patient blood transfusion, give the patient lactate ringer of normal saline, and stop the bleeding, and the patient will recover. Then the second one is cardiogenic shock. The cause of cardiogenic shock is failure of the left ventricle. So the cardiac index decreased a lot. And because of heart failure, the blood cannot be pumped out from the left or right ventricle. So the blood will accumulate in our veins, our pulmonary veins and our SVC, IVC. So actually when the cardiac function decrease a lot, the wedge pressure will raise. The CVP will also raise. And the resistance will raise because of increased sympathetic tone. So to treat cardiogenic shock, first of all, we need to know the reason. If the patient has a myocardial infarction, we need to revascularization of the coronary arteries. And also, we use some drug called inotropic agents. Inotropic agent increase the contractility of the heart, so can reverse the decrease of the cardiac index to make this patient recover. So for cardiogenic shock, we give inotropic agents. And for septic shock, this is different. This is caused by the systemic vasodilatation by the toxins, by the immune response. So our systemic vascular resistance decreased because of systemic vasodilatation, but our cardiac function remains normal or even increased because of the sympathetic tone. So to treat patients with shock, septic shock or infection, the first of all is the antibiotic to kill the bacteria. Then we need to give a lot of volume expansion, because although our volume is remain the same, but it's redirect to a third space to the capillaries. So first step, we need volume expansion. Then we give vasopressors. Vasopressors increase the resistance to keep our blood pressure, to keep our organ perfusion. So to treat septic shock, antibiotics plus volume expansion plus vasopressors. So I think in summary, in our session today, we talk about normal circulation system. And then the second part, we talk about some important pathophysiology of our heart. And here, this QR code is the link to the full PowerPoint file stored in my Google Drive. You can scan this QR code to download the slide I just used. So I think the time is up, and I will stop here. So thank you everybody for attending. And if you have any question, you can type in the chat sessions, and I will try to answer you one by one. Okay, thank you very much. Okay. If anyone need a slide of this lesson, just scan this QR code. I will keep the link for like 3 minutes.子欣还在吗？